We are live.
Welcome to all of you. Good evening, my dear colleagues. I, Dr. Anil Shah, President for Maharashtra Chapter, welcome all of you to this wonderful series webinar that is A to Z of Manual Small Incision Cataract Surgery. Today is episode 18, part 1. The title for today's webinar is Simplifying the Complex SICS for Challenging Cataracts. The aim of SICS webinar is to popularize SICS by series of webinars to enrich our knowledge, to emphasize how SICS is safe, cost-effective, with minimum learning curve, to emphasize its usefulness for community basis, to involve expert surgeons to share their knowledge and experience, and to make SICS interesting and a popular technique. Here are a few important quotes. A challenging cataract is an opportunity for innovative surgeon. Mastering SICS is not about fighting complexity, but embracing simplicity and precision. Every complex case has a simple, elegant solution. SICS is the art of finding it. Precision in SICS transforms challenges into confidence. A surgeon's skill is measured not by difficulty of the case, but by the ease with which they resolve it. Here are few photographs showing complex, challenging cataract. For this webinar, we have chairperson Dr. Prakash Marathe, Dr. Usha Johri, and the speakers who are expert in their field with the best of their knowledge and experience. We have Dr. M. Nivian, Dr. Shilpa Joshi, Dr. Pradeep Mohanto. And to discuss this topic, who will argue and debate and dialogue, we have Dr. Mandar Paranspe, Dr. Satanshu Mathur, and Dr. Shekhar Paranspe. The moderators who will preside over the webinar, making the discussion enjoyable and effective, we have Dr. Aarti Heda and Dr. Ameya Kulkarni. I am really very much thankful to the chairperson, speaker, discussant, and moderators for sparing their valuable time and making this webinar a grand episode. Thank you. I will hand over to Aarti for.
So good evening, everyone. Welcome to the 18th episode of A to Z of SICS. I'll just quickly introduce the office bearers of ISMSICS. Dr. Amulya Sahu sir, who is founder chairman of ISMSICS. Dr. Jagannath Boramani, who is executive chairman of ISMSICS. Dr. Parikshit Gupte is the vice chairman of ISMSICS. Dr. Satanshu Mathur is chief national coordinator. Dr. Barun Nayak is president of ISMSICS. Dr. Deepak Mishra is secretary of ISMSICS. So I'll quickly call upon the office bearers of Maharashtra chapter of ISMSICS. We have with us Dr. Prakash Marathe sir, who is chairman of Maharashtra chapter of ISMSICS. Over to you, Marathe sir, for your few words.
Good evening, everyone. Respected office bearers of ISMSICS, then office bearers of Maharashtra chapter of ISMSICS, speakers who have been invited today, Dr. Niven, Dr. Mohanta, and Dr. Shilpa Joshi, chairpersons, discussants, and all the delegates who have joined this webinar. I think this is the wonderful series by Maharashtra chapter. Maharashtra chapter is one of the vibrant chapters in the country. We have taken this initiative under the presidency of our friend Dr. Anil Shah. And I think A to Z of SICS, what I add that alpha, beta, gamma of SICS is also being covered. And today we are moving forward with the syllabus of SICS, and challenging cases will be shown by our experts here. And the discussion about those cases will be done by discussants as well as chairpersons. And all the delegates definitely will be benefited by this. The experts in SICS as well as new learners who are willing to learn more about SICS across the country. And taking this chapter of Maharashtra chapter of ISMSICS forward and spreading SICS across the whole world, which is the mission of ISMSICS. Best wishes for today's webinar and welcome everyone again. I wish all the success and all the best for today's webinar. Over to you. Thank you.
Thank you so much, Marathe sir. We have with us Dr. Mandar Paranspe sir, who is vice president of Maharashtra chapter of ISMSICS. So Mandar sir, over to you.
Yeah, thank you, Dr. Aarti. This is a wonderful series on ISMS ICS, elaborating on the various complex as well as simple techniques that this particular surgical technique has given us. And kudos to our President of Maharashtra chapter, Dr. Anil Shah, sir, for initiating this wonderful series, which is going to be a treasure of information for anybody who wants to understand and learn and master the technique of SICS. So we are going to have some great presentations from great stalwarts of SICS today as well, and we look forward to it. And then we will also have some good discussion on the various aspects that will be presented today. So I extend my best wishes for today's webinar. Thank you.
Thank you so much, Mandar sir. Next, I call upon Dr. Usha Johri ma'am, who is Joint Secretary of Maharashtra Chapter of ISMSICS.
A very good evening to all of you. I must congratulate Dr. Anil Shah for having taken such great efforts and consistently working on this, starting right from basics to what level that he has taken. It's really a lot of hard work that he has put in, and with the efforts of the wonderful team which we have with us, he has made it possible. And I'm sure, as Dr. Marathe has mentioned, that Maharashtra, I think, is leading in this ISMS's Zoom meetings, webinars, and wishing you, Dr. Anil Shah and the team members, the very best. And we have wonderful speakers. I know most of them, and hope to learn something new. And good luck to all of you. Thank you.
No, Aarti, you are muted.
So sorry. So now I invite Dr. Amay Kulkarni, who is Secretary of Maharashtra Chapter of ISMSICS, to take the session forward. Over to you, Amay.
Thank you, Dr. Aarti, and good evening to every one of you. I'm here to give a short introduction of our chairpersons for today and our speakers. In chairpersons, we have Dr. Prakash Marathe, Dr. Anil Shah himself, and Dr. Usha Johri ma'am. So I'll start with Dr. Prakash Marathe first. He's the chairman of the Maharashtra chapter of ISMSICS currently. He's also the past president of Maharashtra Ophthalmological Society. He's held various posts in IMA, and he's a very senior surgeon practicing in Pune. Dr. Anil Shah sir is the president of the Maharashtra chapter of ISMSICS, and he practices in Nandurbar. Dr. Usha Johri ma'am is the joint secretary of ISMSICS Maharashtra chapter. She's also president women's wing of ISMSICS. She's also past president of Bombay Ophthalmological Society. In speakers, we have Dr. Nivian, who said, just tell that I'm from Chennai and that is enough. I appreciate your candor, sir. So he's an anterior and posterior segment surgeon. He's done his MS from Arvind Madurai. He's done his VR fellowship from Shankar Netralaya under Dr. Lingam Gopal, and he's won various awards at AO and DOS. We have Dr. Shilpa Joshi madam, who practices in Pune. She heads the cornea department and is the medical director of eye bank at HU Desai Eye Hospital, Pune. She's won the VK Chitnis Oration Award at MUS. We have Dr. Pradeep Mohanta, sir, who's done his MBBS from Kolkata Medical College. He's done his MS from PGI Chandigarh, his VR fellowship from Shankar Netralaya, Chennai. He is currently the member scientific committee of AIOS, and he practices in Ranaghat, West Bengal. So welcome all of you, and over to you, Aarti.
Thank you so much, Amay. So it's an honor to introduce today's discussants to you all. We have with us Dr. Shekhar Paranspe sir, who is in private practice since the year 1983 in Sangli. Other than ophthalmology, he is sports enthusiastic with special interest in badminton and table tennis. Next, we have with us Dr. Satanshu Mathur sir, who runs High Tech Eye Institute and Laser Center in Kashipur in Uttarakhand. Next, we have with us Dr. Mandar Paranspe sir, who is Vice President of Maharashtra Chapter of ISMSICS and has been in private practice in Pune, and he's an excellent surgeon. So with this, we've come to the end of the introduction. So let's move on with the talks. So first, I would like to invite Dr. Pradeep Mohanta sir to talk on SICS for an intumescent cataract and hypermature Morgagnonian cataract, and double SICS for a rock hard cataracta niagara. So over to you, Mohanta sir, for your presentation.
Hello, am I audible?
Sir, you are audible.
Sharing my screen. Desktop is front. Desktop আসলেই হয়ে যাবে। Is it visible?
Yes, sir.
Is it visible?
It is visible, sir.
Hello, am I audible?
Sir, you are audible. Can you hear us?
Hello,
Sir, you
Am
are
I
audible, sir.
audible? You are audible? Am I audible now?
am I audible?
You're audible, not a problem.
Mute
Yeah.
হয়ে গেছে কেন?
Mohanta sir, we can hear you. You can go on.
Unmute করতে হবে।
I think I'll just message him.
এটা মিউট রয়েছে।
এবার আনমিউট হলো, এই যে কথা বলুন।
Hello,
এবার দেখুন, বলুন বলুন।
am I audible?
Yes, sir. Mohanta sir, you are audible.
ঠিক আছে, সবই তো শোনা যাচ্ছে।
Hello, Aarti, am I audible?
Yes, sir. Yes, sir. You are audible.
Okay. So this is an intumescent cataract. So it's very important to make the tunnel. In intumescent cataract, in this case, we are expecting a nucleus of hard nucleus. Size of the nucleus will be about 7 millimeter. So the incision size is to accommodate the nucleus. So after making the tunnel, we have to make a side port. I'm going to stain the capsule with trypan blue dye. In intumescent cataract, the main challenge is to do the capsulorhexis. So after staining the anterior capsule, I am making an entry of 2.8 millimeter so that I can use a utrata forceps. And now I make an incision and make a small tag with a needle, and through this 2.8 millimeter wound, I go and make a small opening, small rhexis first, a mini rhexis, and then aspirate some lens matter to decrease the intralenticular pressure. And then we inject visco, fill up the chamber, take a scissor, Vanna's scissor. Before that, I am going to enlarge this 2.8 millimeter wound little larger, only this side. So it is about, say, 3.5 millimeter. Make a small cut at the margin of the mini rhexis, and then enlarge the rhexis. Now, when the rhexis goes at 9 o'clock, it tends to go to periphery. We hold the tag and make small jerky pulls like this, and it comes to the track. And now we have to open the tunnel completely. We cut with forward movements so that the corneal valve is right. And now we have to prolapse this nucleus into the anterior chamber. I take 2 hooks One goes below and the other rotates, and the nucleus comes in the anterior chamber. And now we inject visco both in front and behind this nucleus. Must protect the corneal endothelium. In this case, I took this irrigating vectis and delivered the nucleus. In this case, I have made a side port on the left side, and I am doing hydroimplantation of the intraocular lens. If we can do this, we save a lot of time. We save time that is required to clean the visco. This air bubble is just to buy time because the antechamber is getting shallow. So we inject air and then hydrate these side ports. And once the side ports are hydrated, we remove the air bubble and replace the air bubble with BSS or young lactate, whatever we are using. I usually put a releasable suture to oppose the conjunctiva. Just 3 loops. Hold the suture and cut it here and remove this suture after 2-3 days. Now, next presentation. Now, shall I go to the next presentation or there will be discussion now itself?
Sir, you can present. We will take the discussion after all the
Okay.
speakers have spoken.
This is a hypermature Morgagnonian cataract. So, incision and this part I am going to forward. Corneoscleral tunnel is made. The side port is made at around 8 o'clock. The anterior capsule is stained. I usually wash the dye so that we get uniform anterior chamber after injecting viscoelastic substance. In Morgagnonian cataract, as soon as we make a puncture at the center of the anterior capsule, this milky fluid comes out. So in this case, what I did is I opened the tunnel completely. I could have opened half of the tunnel and do the rhexis, but in this case, I opened the tunnel completely, injected, aspirated the milky fluid. And now, as I'm trying to do rhexis, there is a fibrous band at around 7 o'clock. And if I pull it, there can be zonular tear. So what I do is I inject visco and then I take a scissor, a Vanna scissor, and cut this capsular tag and then make another cut here and take the, again inject some visco, take the utrata forceps and do rhexis in this part. Inject visco again and then make a cut here with scissor. Take the utrata again and complete the rhexis. And now this nucleus is to be prolapsed into the anterior chamber. This is about 6.5 millimeter wound or 7 millimeter wound. So prolapsing the nucleus in the anterior chamber. With the help of two hooks. Inject visco. And in this case, I am going to use a fish hook, which I make using bending a 30 gauge needle. Just go and take it out. And then cortical cleanup is done and intraocular lens is implanted. The next presentation. Is there any more time? I wanted to show one more.
So you can go ahead, sir. We have 3 minutes.
If it is a black cataract, if it's a very hard cataract, I make two small incisions side by side, and this incision looks like this V-shaped incision. This is 5 millimeter and this is also 5 millimeter. So it becomes a 10 millimeter wound. And after making the tunnel and prolapsing the wound, we have to make a very large rhexis in such cases. Prolapse the nucleus. And then take, I use irrigating vectis to remove this. The pupil became small, but we could remove all the cortex nicely, place the lens in the bag, and just put on suture at the middle, at the apex of this V-shaped incision. And this, all patients do very well with this technique. So this is for a person who doesn't do a regular ISMSICS. We're making a large wound and taking a very hard nucleus out. Dr. Shah uses the snare. That is for if you are using a snare regularly, then you can use it. Otherwise, this is a good technique for a person who is not doing ISMSICS regularly. Thank you very much.
Thank you, sir. Thank you. Thank you, sir, very much.
Thank you so much, Mohanta sir, for excellent surgical videos and very meticulous surgical steps. So we'll take the discussion after all the speakers have spoken. So next I invite Dr. Silpa Joshi ma'am to speak on SICS in hazy corneas.
Excuse me, I'll be going out after 10 minutes. I have some urgent thing to do. So if you want to ask any question, please ask right now.
Okay, can I ask, sir?
Yes.
I think it was a wonderful surgery, intermittent cataract you have tackled very nicely. Is it your routine practice to put the stitch in all cases of SICS?
Usually I put on stitch. Otherwise, I just inject gentamicin and dexamethasone subconjunctivally, and the conjunctiva goes forward and it goes near the limbus, and put a patch overnight, and it is like that.
Because most of the times nowadays people compare it with the phaco, though we don't want to compare it. And it is like stitchless and everything, that particular word comparison people keep in mind. And your surgery is fantastic. Of course, without stitch, definitely it is a good surgery. But putting stitch, patients may be asking this question that have you put the stitch? I was expecting some stitchless surgery. Hence, I asked you that question.
I don't give any hope to those patients that it will be stitchless surgery. So my patients doesn't ask any questions to me.
Good.
Sir, one question I want to ask you.
Yes, sir.
Sir, do you use a glass syringe for aspirating cortex with a Simcoe cannula or a plastic syringe?
So I feel comfortable with glass syringe. With plastic syringe, it's very hard. It hurts my fingers.
Okay.
I use a glass syringe.
2 cc or 5 cc, sir?
I use 10 cc.
10 cc? Oh,
Yes.
okay. One thing I wanted to suggest, sir.
Yes.
If you can connect the aspiration port to phaco aspiration, and then you can do aspiration via Simco with the phaco machine, then it will be also a good aspiration, sir.
Okay. Okay.
So you don't have to take out each time Simco cannula out and again insert it and flush out and again insert it. So you can connect the silicon tube to aspiration port of the phaco machine, and you can aspirate to the Simco cannula also.
Okay. Right. Right.
Thank you, sir. Thank you very much, sir.
Thank you.
So
I
if
had
we
one question for Dr. Mohanta.
Yes, sir.
The last case which you showed of double incision, although it looks very nice and probably it's doing good in your hands, but I feel that especially for these kind of cataracts, I would rather go for a conventional ECC incision and maybe take a couple of stitches or 3 stitches so that you sleep well at night, because a 10 millimeter incision, all said and done, is probably not a very stable incision. So, and second thing is, in probably in such cataracts, if the cornea permits, then phaco-fracture could also be, or even the hard cataracts, phaco-fracture could be an option where you can probably limit the size of your incision and deliver the heminucleus to a slightly smaller incision, maybe 6 or 6.25 millimeters.
Yes, sir. The ultimate goal is patient should get clear cornea, good vision postoperatively. So whatever surgeon should be given some liberty. Whatever works good in surgeon's hand and patient gets good result, that is good, I think. And in this technique, it's like ECC, these two double SICs, just like ECC. One incision is enough. If any surgeon feels that it is dangerous, put 2 more incisions on 2 sides.
Dr. Mohanta, sir, I think you are phaco surgeon also, right? You do SICs as well as phaco.
So I do 90% phaco and only 10% SICs.
So you know both the aspects of both the surgeries. That's nice.
Yes.
And if we don't have any more question, should we move on to the next talk?
Yes, I think.
So next I invite Dr. Shilpa Joshi ma'am.
Good evening, everyone. At the outset, thank you very much, all the office bearers of ISMSICS, Dr. Anil Shah, Dr. Aarti, all the chairpersons, respected chairpersons, and the panelists. I'll start sharing my presentation.
Ma'am, your video is off if in case you want to switch it on.
Yeah. Is my screen visible?
Ma'am, your screen is visible. We just have to go on the slideshow mode.
You make it full screen.
Yeah. Okay. The topic is SICS in hazy corneas. Cataract surgery nowadays has become almost like refractive surgery, where the surgeon as well as the patients, they expect a perfect unaided 6/6 vision for near as well as distance. But there are certain situations where it is less than optimal scenarios, like a pre-existing corneal haze or corneal pathology or pre-existing glaucoma, shallow anterior chamber, pseudoexfoliation, or some other things where these are the challenging cases. And this presentation is about such challenging scenarios, SICS in compromised corneas. So the corneal pathologies that we come across in our clinical practice that usually are corneal scars or opacities following infectious keratitis or following traumatic corneal tears. Fuchs dystrophy is another thing which we may see time to time. Pterygium is very common in our Maharashtra and Western Maharashtra side. Autoimmune conditions such as rheumatoid arthritis, cicatricial pemphigoid, and post-keratoplasty cataracts, which I often see in my practice. So, cataract surgery in these corneal scars or in hazy corneas. Before we start planning for the surgery, the first question we need to answer is cataract surgery alone sufficient, or is a keratoplasty, a PK, or a DALK or a DSEC is needed? That would depend on the type of opacity, whether it is partial thickness, full thickness, location of the opacity, whether it's peripheral, paracentral, or involving the visual axis, surgeon factors, expertise of the surgeon, of course, availability of donor tissue and access to eye bank, and visual requirements of the patient. So if it's a bilaterally blind patient with not much family support or relative supports required for follow-up after keratoplasty, then he's probably better off with just a cataract surgery alone, so that he at least gets ambulatory vision rather than advising him keratoplasty. So cataract alone can be done, or SICS can be done in small corneal opacity, partly covering the visual axis. SICS with optical iridectomy can be done in corneal opacity, totally covering the visual axis. And a SICS or a phaco with a phototherapeutic keratectomy can be done in a superficial corneal opacity, involving the visual axis, a nebular corneal opacity. On the other hand, combined procedures are needed if there is diffuse corneal involvement of the anterior part of the cornea, or sparing the descemetes, sparing the endothelium, then superficial anterior lamellar keratoplasty or a deep anterior lamellar keratoplasty can be done. If there is endothelial involvement, then obviously a DSEC or a DMEC is needed. And if it's a full thickness involvement, then a PK triple is needed. Now, IOL power calculation is also a challenging scenario in these situations. IOL master is many times not possible. So axial length measurement should be done either by vector B scan or immersion scan. Fortunately, axial length measurement has a better reproducibility and consistency than the K reading. And choice of the IOL formula does not really affect the IOL power prediction. Sometimes people do this intraoperative aphakic refraction method also for better calculation of the IOL power. That means after taking out the cataract, it's probably an older method, but people still do it, doing the retinoscopy, finding out the refraction in the vertical and the horizontal axis, taking the average and calculating the IOL power from that. So manual keratometry can be done if central 3 to 5 millimeter zone is clear. Most of these patients, they have irregular corneas and very poor tear film. So topography is usually needed. If we have access to pentacam, then EKR, that is equivalent keratometry readings in the central 3 to 5 millimeter zone. This will calculate the anterior as well as the posterior curvature of the cornea, which is useful in these situations. This can be taken. Of course, if nothing is available, then standard 43, 44 diopter K reading can be taken. Some people take the other eye K reading also. And in post-keratoplasty scenarios, it's better to wait till the complete suture removal is done and a stable topography is obtained 6 to 8 weeks after that. So IOL power calculation can be done after that. Coming to SICS in Fuchs dystrophy, if it's an early stage Fuchs, then it can be missed on the cursory examination because this fine endothelial dusting or the peripheral guttae changes, they can be missed if we are not careful enough. The advanced stages, of course, there is a clinically obvious corneal edema. A better way to do the examine the endothelium is a simple, very basic technique of specular reflection, in which the bitten bronze appearance of the endothelial guttae, they are seen as dark areas, can be easily visualized. Or alternatively, with a dilated pupil on retroillumination, these changes also may be visible. Specular microscopy is recommended in these situations, not only in Fuchs, but elderly patients above 70-75 years of age, hard cataract, pseudoexfoliation, advanced glaucoma, chronic recurrent uveitis, and in patients with history of corneal edema or decompensation in the first trial after surgery. Because many of these have underlying Fuchs dystrophy, which may not be that clinically apparent, but they are at a high risk of developing decompensation in this eye also. So this paper gives us the guidelines for the high risk factors in case of Fuchs dystrophy patients undergoing cataract surgery. The chances of decompensation are high if the endothelial cell density is less than 1500, if the coefficient of cell surface variation or polymegathism is more than 0.4, if the hexagonal cell percentage is less than 60, or pachymetry is more than 600. So is FECO or SICS in Fuchs dystrophy? SICS is many times preferred because FECO is likely to cause more endothelial damage because of fluid disturbances, nuclear fragment shattering, etc., use of FECO energy, etc. SICS is a safer technique, better in these eyes with poor visibility. It is faster than FECO. Use of a soft shell technique, as it has been described, combination of a dispersive and cohesive viscoelastic to protect the endothelium and to form the AC well. This can be done. All the techniques of SICS, as the blue menthol or using irrigating vectors or using the snare or the FECO fracture or all the other techniques, they seem to work well. What should be done is that all the steps should be in one go, especially the nuclear prolapse and the delivery should happen in one go to minimize the endothelial trauma in these situations. Of course, post-cataract management is also challenging because these eyes take longer time to recover, and steroids, anti-glaucoma, hypertonic saline, etc., drops and ointments, they need to be given for longer time. Intermediate term outcome of these cases is good. They seem to do well over the next few weeks or months even, but long-term outcome is not so good, and there may be a need for keratoplasty 2, 3, 4 years down the line. So patients need to be counseled that in spite of uneventful cataract surgery, because of the progressive nature of this dystrophy, they may land up in the corneal decompensation and may need a keratoplasty. Coming to SICS in corneal opacities, the biggest challenge here is poor visualization. Plus, there may be several comorbid factors such as hard cataract, poorly dilating pupils, zonular weakness, AC is shallow or irregular, so there is less working space. And plus, because of the opacity, there is scattering of the light and annoying reflexes, which further make the situation difficult. So this is a video of SICS in a case of peripheral adherent leukoma with a small pupil and hard cataract. Staining of the capsule is absolutely essential in these cases. So after the staining is done, I tried to release the Synicae with the help of the microvanas. It's better to cut those Synicae or adhesions rather than using the iris repositor, because that can cause desmet detachment at that place. Then the pupil stretching is done with the help of the wire dialers, and then the rexis is done. I always give relaxing incisions in case of hard cataracts like this. Again, minimal maneuvering should be in these steps of the nucleus prolapse and nucleus delivery. This was a situation in which there was a central corneal scar post Hansen's disease in this patient, and the visualization was very, very poor. Despite putting visco or trying other things, the visualization could not be improved. So I used a light pipe or endo-illuminator in this case. After releasing the synechiae with the repositor, again, stretching of the pupil was done. And next steps, especially the rhexis, is a challenging one. And because of scattering of light, under the microscope light, it's very difficult to complete it. So there comes the use of endo-illuminator held at the limbus, which provides oblique illumination. So it is especially useful for the rhexis and cortical wash. So at that point of time, I switched off the microscope light and completed these things under the endo-illumination light. So under this oblique illumination, the visibility is a lot better, and all these steps can be done relatively easily. Similarly, putting of the IOL is under the endo-illuminator light. Of course, if these things are not available, then many people use the alternative of constantly putting the visco on the cornea, and or some people they uh, dip they fill the contact lens with the visco and put it on the cornea for better visualization. Last is SICS in post-therapeutic or tectonic or optical PKs. Again, a challenging situation. There is a graft there with limited number of endothelial cells, complicated cataract, PS, and all these situations, visibility, visualization as usual is hampered. But what is a bigger problem in these situations is the graft rejection, which is invariably it's likely to happen post the cataract extraction. So we should be watchful for this, and post-operatively steroids in all form, depending upon the severity of rejection. Topical, oral, subtenance, intracameral, or even IV methylprednisolone is needed in such situations. So to sum up, SICS in corneal comorbid conditions is a challenging situation, but with the help of certain modifications in surgical technique and careful pre-operative workup and certain post-operative uh, careful management, a reasonably good outcome can be given to these patients. Thank you.
Thank you so much, Dr. Shilpa ma'am. It was a very detailed talk with excellent surgical videos. So we'll move on to the last speaker for the session. Now I invite Dr. Nivian, who is going to talk to us about aphakia, what are the secondary IOL options in MSICS.
Thank you, Aarti. I'm just going to share my screen. Yeah. So respected teachers, senior ophthalmologists, my dear friends, So I'm going to talk about the various secondary IOL options in SICS. So first, I'm going to start off with this particular case of a brown cataract. So this was a dislocated lens. So it was planned for a lens extraction with a retropupillary iris claw lens. So that is one of the easiest lenses to implant in these scenarios. So just one point I like to highlight is a careful preoperative evaluation in these cases. So that is why I used the word a planned lens extraction was done. So as Dr. Pradeep sir already mentioned, in these hard cataracts, large nucleus, it is always safer to have a larger incision than usual. So here, because plan, I just made a trocar to make sure that the hypertony is avoided, but you can also use an AC maintainer. This actually reduces the amount of viscoelastics that you use. As you can see, once you enter itself, the entire nucleus pops up so that the entire nucleus is actually dislocated. So here the main care must be taken that we don't drop the nucleus. So make sure that the vectors go underneath and using the sandwich technique, slightly bringing it to the anterior chamber. And you can see how easily the entire nucleus had come because it was dislocated. So the second important thing in these cases is a good anterior vitrectomy. So the golden rule is I always prefer to stain the anterior chamber with tricot and then wash it. So what this happens is once you wash it, only the vitreous strands get strained. So you know how much of vitreous to cut. And there is some amount of the tricot that goes inside. So that also helps in avoiding post-operative edema. As far as anterior vitrectomy is concerned, for anterior segment surgeons, the trick here is to make sure you always stay in the center. So in this case, since I have an infusion, my other hand is free. Otherwise, you can have one side port the infusion and the other side port the cutter. So always stay in the center. We don't have to go under the iris or the areas where you don't see the cutter because that could be dangerous and sometimes it fastly cuts the iris. As long as we do a good anterior vitrectomy and clear the wounds, so it is safe to do an implantation of a secondary IOL. As I said, in this case, we are using the iris claw lenses. So two instruments that are very important. As you can see, this is like a broad crocodile mouth forceps. So basically it helps to have a good grip of the lenses because one of the common difficulties people face, they say, is when they try to clip, the lens keeps slipping. So always have this slightly broader iris claw forceps and have a good grip. The second thing, if you notice, my second instrument is already inside and it is at the mid periphery. So basically that tells me where I want to clip the lenses. So since you know it's a blind procedure under the iris, sometimes we put the lens inside and then we end up searching for the places. So that can cause some iatrogenic tears in the iris and it takes a lot of time. So my trick here is I make sure my second instrument is there. And if you notice carefully, I'm taking the lens underneath that to the place where I want to clip. Now the third important rule here is your right hand has to move upwards and your left hand moves down. So when this happens simultaneously, you can see the iris tissue getting tucked inside there. And then you can see a small dimple that comes in the mid periphery that assures that the lens is clipped. So just making sure that visco is put only in the anterior chamber. Why I prefer the infusion or the AC maintainer is otherwise we end up putting a lot of visco. And because you know these cases are aphakic cases, a lot of visco tends to go inside. So that could be one of the reasons that causes glaucoma or inflammation post-operatively. So here again, to the second, clipping the second haptic, my second instrument is already inside where it has to be clipped and the clipping is done. So it's a relatively very easy and a fast procedure. The only thing again here, if you can see the dimple there in the mid periphery. So why mid periphery is if you go to anterior, that is when you get the cat eye pupil, or if you go to posterior near the roots of the iris, that can cause bleeding or hyphema in these cases. So you do get nice round pupils and you can always wash the anterior chamber of the visco. And sometimes you get these pigment deposits. So all those things can be washed before you close the case. Usually some prefer to put an air bubble. So moving on to the second case, here also it was a case of an SICS. As you can see, it was a large rent. Here again, after staining, if you notice, there is only one strand of vitreous. So the point I wanted to highlight here is sometimes we also are moving towards the pars plana approach using the trocar for doing vitrectomy, even for anterior segment surgeons. because we have a lot of wet labs in SSTC and things. So when you can do intravitreal injections, I think making a trocar is not that difficult, but making sure you have the instrumentations always ready is the key here. So the studies have shown that when you do a pars plana approach, the amount of vitreous you cut is also less. It is actually faster. As you can see, even though it's a large rent, there are only a few strands of vitreous. So once you relieve these vitreous, you don't have to do further vitrectomy, because sometimes when you do the anterior approach in large rents, more and more vitreous tends to come, and sometimes you don't know when the end point is. So as long as you clear the vitreous in the pupillary margins and in the wound is also very important, because you don't want any vitreous in the wound. So now here again, just checking for the integrity of the anterior capsule. So we have the anterior capsule intact. The third thing, when I put viscoelastic, I make sure I put visco between the iris and the anterior capsule. You don't have to actually fill the anterior chamber in these cases. So you just want to create a space between the iris and the anterior capsule. So here I'm going to use a rigid 3-piece lens, one of the best and safest lenses when you have rents, even in phaco when you want to convert. The technique that I use is the 2-step approach. So first I make sure that the leading haptic goes inside. So you just push the iris, so you can actually visualize the anterior capsule, and you just place it and leave it there. So you don't have to force yourself inside, because sometimes I've noticed when you try to force both the haptics inside in one shot, the lens keeps coming out. And then you do multiple attempts putting visco. So you use this 2-step approach where I just leave the leading haptic inside once I know it is in the sulcus. I go to the side port at the optic haptic junction and take it to the area where I can see the capsular margin very clearly. That is always inferior to me. So I know exactly where I'm dialing the lens. And once it is in position, I avoid more maneuvers, because sometimes when you try to dial these lenses, there could be some places where it actually slips back. So once you have done this and you know it is in position, it is best to just leave it. And again, while washing, make sure you don't have a high bottle height, because when you have these large rents, even after that, when you wash also, it can go inside. And then put an air bubble and close. The other option that is available, now we do also have the foldable options for these SICS cases when you have a complication. So this is the CMT Flex IOL. This is a single piece hydrophilic lens with specialized T-shaped haptics. So this was again a case where you can see SICS that was done, 2 sutures was put, and the patient was left aphakia. You can see a case of asteroid hyalosis. So we know that these cases, the PCs are thin and visibility is poor, and there are more chances when you have the whole bag coming. So as you know, for any scleral fixated secondary IOL, the 0-180 degree is very important. So first we mark the 0-180 degrees here, and we make a scleral glue. So this is like a slightly modified technique of using the CMT Flex IOL. Instead of making the full flap, we just make a groove, because you just need the T to sit under the sclera. So 1.5 millimeters away from the limbus, we make a 23 gauge sclerostomy using a needle on both the sides. So the other advantage of this lens is it can be loaded into any foldable IOL cartridge. So sometimes in these complicated cases, you don't have to open up the existing SICS wound, because sometimes it may be ragged and opening it up and extending can be messy. So the other advantage is you can use a separate clear corneal incision here. You can see we have specialized T forceps also. So the aim is to inject the lens. You can see the T haptics coming out first. So just hold on to the T-shaped haptic, as you can see here. And now don't pull, because this is a single piece foldable lens. So inject the remaining of the lens inside. And then once the lens is free from the cartridge, so gently you try to pull it out. You can see the pop of the T, and the T haptics are out. So just a small animation clip to show you. Inject the lens. You can see the T-shaped haptic there. Just hold the head of it. And once it is free from the cartridge, just gently pull it out of the sclerostomy. At the sclerostomy, there might be a slight tug because of the thickness of the instrument. So don't try to pull with force. Just wait there with your force, and it gently slips out. And because of these specialized designs, they just stay there without any tucking or suturing. Now for the other side, we use the handshake technique. So using the arm of the, we're exchanging it to the other T-flex forceps, and then again, gently pulling it out. So once it is there, as I told you, the 0-180 degree is the key here. So once the lens is out, you don't have to do any other procedures. As you can see here, the lens is well centered. You can see these round pupils, and there is no tilting of these lenses. And one more point in any of these secondary IOLs is, if you're not sure that if any vitreous stand is there, or after finishing the case, you can always again inject some tricot and just wash it to just make sure, because in this particular case, we didn't do much of a vitrectomy. So you can either glue the flaps or even you can just cauterize it or suture just the flaps. This is just basically to oppose the scleral flaps and not for holding the IOL in place. And the last option I'm going to talk to you about is a flange technique that can also be used. So here again, we have a large brown nucleus that was more than 270 degrees dislocated. Again, having a good scleral tunnel is a key. Make sure your side pockets are also made well done, because you don't want any difficulty in removing these nucleuses, damaging the endothelium or any of the fragments dropping behind. So, and then this particular case, sometimes if you see any vitreous, it is always better to do a limited vitrectomy just to free the nucleus before removing these dislocated lenses. Because later on you can have some tears in the periphery. As you can see, again, making sure you guide the nucleus into the vectors, good amount of visco to protect the endothelium, and then gently remove the nucleus in toto with the bag. So this technique, as I said, the flange. So basically you need an 80 Prolene needle with a straight needle on both sides. So again here, after marking the 180 degree line, 1.5 millimeters away from the limbus, you enter inside. You do not have to open the conjunctiva or the sclera here. And in the opposite side, you insert a 30 gauge needle. So now basically we are going to railroad this needle inside and bring it out of the other side. So once the needle is out, just pull it. Now you see that the suture has bisected the eye into two halves. So I'm just going to pull the suture out. So this actually is a modification of a technique where you go one side and come through the main wound and then do the same thing on the other side. So you pull the suture out and then you cut it in the center. So you have 4 loose ends. So the advantage here is you can still use your same single piece lenses that you use for SICS, which has those 2 dialing holes. So basically you just have to thread the needle inside the dialing hole, one from below up and the other side from above below. This is basically when you tighten the lenses, you avoid the torsion of these lenses. So once that is done, you use the heat cautery and flange the suture. So as you do in the flange IOL, so you flange the suture. The trick here is that bulb that you see, you should see, just pull it and see that, make sure it is larger than the size of the hole, because we have had cases where some of the rigid lenses have a slightly larger diameter. So just try it and see. So as long as it's not coming through the hole, you know that the flange is adequate. And then you push the lens inside. So now here again, after you push the lens, centration is very important. So once you center the lens, you hold on to one side. So you know that it is centered, and then flange the sutures that are outside. So even though the lens is tilted, it is not that. You have actually measured it and then you're flanging it actually. So here also you just flange the suture that is outside on both the sides. As you can see here, and then the flange can be pushed under the conjunctiva. So this is also a relatively simpler technique for doing to flange a rigid lens with using the suture. It's a slight modification of the existing technique. So you, as I said, you don't have to use the trocars because I'm a VR surgeon. I'm more comfortable with that. You can use the AC maintainer. So these are some of the post-operative pictures on day 2 weeks. So once again, thanks to the entire ISMSICS team, and special thanks to Maharashtra chapter and Dr. Anil sir for having me here, and Harti for inviting me for this wonderful webinar. Thank you.
Thank you, Dr. Nivian, for those wonderful videos. Is your flange technique a slight modification of what Dr. Canabrava does?
Yeah, correct.
Yeah, okay. Great
With
video.
the foldable lens, this is the rigid.
Yeah. Great video, sir. I would now like to invite our discussants. We'll start with Dr. Shatanshu Mathur, sir. Could you please give us your thoughts on
Thanks.
all the presentations?
Thanks, Amey, and congratulations to MOS for continuing this SICS webinar regularly, Dr. Lisha sir. Dr. Niven has presented very well. I have not seen other because I was in the OT. Dr. Niven has presented, said very well one thing. Every anterior segment surgeon should know the vitrectomy. Not only anterior vitrectomy, but through the trocar, the partial pars plana vitrectomy also. It is very easy. We are running SSC course. We are teaching everyone. Every anterior segment should know. That will make your work very easy. Number one. Number two, first case, Niven has shown iris pro lens. So the iris pro lens tip and trick is it is a blind procedure. You don't know where the notch because it goes behind the iris. So you keep your tip of the forceps holding the IOL in the same direction where there is a notch. So when the IOL is behind the iris, you know from the tip of the forceps that this side will be the notch of that on the haptic. So you can just press over the iris and that will go inside the notch. So holding the tip of the forceps in the line of the notch on the haptic is very important. CT flex lens is very good lenses. We are using it, and it is developed by Niven. It is modified regularly. They are very good lenses and very good result we are getting from it. This technique is shown by the modified technique, what he has said. That is done in many ways, but what he has shown, that is I think seems to be very comfortable and easy. Thank you, Niven, for joining us.
Thank you, sir. Thank you for all your SSTC program. Even fortunate to be a teacher there, isn't it?
Welcome.
Thank you, Dr. Sitanshu, sir. I would now like to invite Dr. Mandar Paranspe, sir, to give his thoughts on the presentations.
Yeah, thank you. We have had three very excellent presentations on various techniques related to cataract surgery, specifically SICS. Just a few comments about Dr. Shilpa Joshi's talk on SICS in corneal pathologies. I think the first thing that all of us need to remember is when we evaluate our patients in OPD on the slit lamp, don't directly look at the cataract. I think that is a common mistake which many of us do unknowingly oftentimes. But I think what we need to learn or we need to understand is look at the first most important part of the optical system, that is the cornea. And as she pointed out, Fuchs dystrophy, which is not very uncommon, particularly in advanced stage when we most often encounter cataracts, is often missed. And because of that, the surgeon may not realize it at the time of examining the patient and may land up in a problem, most often post-operatively with with the corneal edema, which does not go away with any medication, and then it is found out that the patient has a Fuchs. So look at both eyes, look at the corneal endothelium, look at that reflex, especially the reflex seen on post-dilatation against the red glow. Doing surgeries in such cases is a challenge in itself. As she pointed out, even the IL power calculation is an issue. And although Pentacam is a good tool, but not many have access to Pentacam. So there are very few things which you can do to achieve accuracy. But what we need to understand is that these patients are having very poor vision as such. So whatever vision that we give, irrespective of the refractive outcomes, is going to be a bonus for them. So you may be excused for not achieving perfection in your IL power in such cases. As far as Dr. Nivian's presentation, excellent videos on the secondary IOL techniques that he has shown. And there are many such more techniques which are being developed on almost a yearly basis. I think what one needs to understand is you have to learn what is comfortable in your hands and master that technique and follow that technique. One point which I would like to make is that we don't encounter secondary IOLs much in our private practice. Maybe in bigger centers or in hospitals where they have a very high surgical load, this is encountered far more frequently. So especially for individual practitioners where the scale is small, where you don't encounter such situations, stick to one technique. Don't try to experiment, because all said and done, these are difficult cases to handle. And because I am not a VR surgeon, I always call a VR surgeon for such cases. I may or may not need his help, but when you need it, you should have it at that moment itself, so that if there is any mishap, especially when you are implanting the IOL, if the IOL slips or something like that happens, then it can be dealt immediately rather than referring the patient later to the VR surgeon, your VR friend. So I once again congratulate all the three presenters for sharing their valuable knowledge on three very important topics. And thank you for the opportunity.
Thank you, Dr. Mandar. I would now like to call upon Dr. Anand Pangarkar, sir, to give his thoughts. Okay. Dr. Prakash Marathe, sir, would you like to give your thoughts?
I think Dr. Pangarkar sir is there.
Yeah, he's here, sir. Okay. Dr. Pangarkar, sir, please.
We have had a series of webinars, all of them contributing heavily, and it is always a pleasure to listen. So today's is no exception, though there were many factors which prevented me from joining in a little early. Regarding the corneal pathologies, as Dr. Mandar has said, we tend to jump onto the cataract in our excitement, but it is much better that we pay attention to all those patients whose cornea are not crystal clear on the first examination, pre-operative. It is always better to do an endothelial cell, get an endothelial cell count done and get a cornea opinion. However, in cases of Fuchs, I have found that your clinical picture and assessment may differ and the post-operative outcome may differ. It is a challenging situation. Regarding the secondary IOS, I entirely agree that you should master one technique and be happy with it. Regarding the iris claw lenses, I have got a small suggestion that if you want to really master it, do these things. Try iris claw lenses in those cases first where there is an intact posterior capsule. That will give you confidence, because I burnt my fingers very badly when the iris claw lens got dislocated and it was very difficult to remove it. That lens behaves very differently on the retina as compared to any other lens. The flange technique is good, but I still go by the suturing technique or the iris claw lens. But all these options are really important. And if you are not familiar with doing vitrectomy, which actually you should get familiar with doing vitrectomy, anti-vitrectomy, there are so many SSTC courses and all to teach you. But if you are not familiar, as Mandar has said, it is better to have a standby VR surgeon in place. And at times, like one of my recent cases, I landed with 180-degree zonular dialysis, 3, 4 o'clock, 5 o'clock. So I stopped the surgery and told him that we will put a iris claw lens in the next visit. It's better that you tell the patient and postpone and do it again. But vitrectomy knowledge and skill set is very important, and get help whenever you feel that there is a small little doubt. Thank you.
Thank you, Dr. Pangarkar, sir, for your words. Dr. Prakash Marathe, sir, if you could contribute.
I think, sorry.
No problem. Shekhar Paransby is there?
No.
Okay.
No, he's not there, sir. He's not there.
Okay.
Okay, I think my previous discussants and chairpersons, they have expressed very thoroughly their views about all those three presenters' videos and their topics. So we already discussed about the first presenter and he has already left. Secondly, I'd like to congratulate Dr. Nivian for wonderfully tackling SICS with all those vitreous cases. He has tackled all those cases where vitreous intervention was there. He showed very nicely with triamcinolone utility. Constellation in those particular videos was fantastic. About Dr. Shilpa Joshi, I think my one straightforward observation, you just tell me whether I'm right or wrong. When there is comorbidity of cataract with cornea and all those corneal conditions, they are with cataract. I think rather than phaco, it is the SICS which should be the first indication. What is your say, Shilpa ma'am?
Yes, absolutely. I mean, already there are lots of factors. First of all, visibility is poor in these cases. Plus, there may be all these factors, hard cataracts, non-dilating pupil, pseudo-exfoliation, subluxated IOL lenses, etc., etc. So always safety first. So SICS is definitely has edge over phaco.
Whenever
It's
we
a
discuss
better
about
technique.
whether phaco is better or SIS, we always say that both the techniques are very nice. But I think this is the peculiar scenario where SICS is preferred over phaco. And this is the reason even phaco surgeons should know how to do SICS. That's what I feel. I think it was wonderful presentation. All three presenters, they were thorough in their knowledge. Their videos were fantastic. Discussion was perfect. And I think definitely all the delegates here who are attending this webinar must have got benefited. Over to you, Dr. Amit.
Thank you, Dr. Marathe, sir. I would now like to ask Dr. Johri madam to give her 2 words.
Yeah, the cases were all very challenging, and the speakers, I would honestly tell, have justified in showcasing the excellent videos. One thing I would want to ask Madam Shilpa Joshi is, supposing you have a case where there is a total corneal opacity and you are unable to assess the extent of cataract. What would you like to proceed? Would you like to do first a keratoplasty? Supposing it's a total corneal opacity, would you like to do a total keratoplasty, or would like to do a cataract surgery, or would you like to do an open sky with cataract together? What is your opinion about it? Because I mean, your cases were really wonderful, and it was the videos that you showed were also very challenging. So I just wanted your opinion about this. What do you do when there is a total corneal opacity?
Yeah, so if total opacity is there with no view of the anterior chamber, obviously the patient is not going to benefit, and we are not in a position to assess the
Assess the
cataract.
extent of the cataract,
Uh,
right?
you know, the patient just doing cataract surgery is not going to help. So in these situations, we have to be prepared for a keratoplasty, and assuming that there is going to be a cataract, even if we find a NS1 or NS2 cataract in the open sky situation, assuming that we are doing penetrating keratoplasty, we should be in a position to deal with the cataract. That means the patient is generally posted for PK triple. So beforehand, only in the preoperative workup, we calculate the IOL power, assuming that the patient is going to need the cataract surgery and IOL.
Thank you very much. And of course, Nivian, as always, has been brilliant in his talks and excellent videos. Congratulations to all the speakers. I think more than the speakers, I think we learned a lot from you people. All three of you were excellent. Thank you very much for having me.
Thank you, Dr. Usha ma'am.
Just a small
Yes,
little
sir.
addition. Even if your corneal opacity is large enough, but a little eccentric, and viewing of the cataract or intraoperative viewing is very difficult, then what you can do, what people have described as moonlighting. Moonlighting refers to the use of the endo-illuminator probe used in vitrectomy to illuminate the anterior chamber. And they have reported that the view is much better than what you would imagine.
Thank you, sir.
Moonlighting actually is a
Absolutely.
term which refers to which has got a very different connotation, like a
Yeah.
full-time employee using
Yes.
his extra hours to earn income. But this also has been called moonlighting, use of moonlight water. But it is a
I've,
nice. I liked it because
yeah,
if
I
you
have
have
become a big
access
fan of that endo illuminator.
to
Some of
yes,
these cases I cannot manage without the use of that light pipe. I'm always troubling my VR colleagues by borrowing their light pipes.
Ma'am, can I ask a question, ma'am? This
Sure.
using of this endo light, is there any particular angle or where it should be put? Like
Depending upon
on the
where
top
you are
or
working,
the
actually.
opacities.
I keep on moving it.
okay.
Tell the sister to keep on moving it wherever I am working. So, all around the limbus, whichever area taking out the cortex or whichever area the rexis is going, just, that area diagonally opposite, it should be kept so that, you get that oblique effect.
And the microscope light is totally off.
Yeah, I switch off the microscope light totally.
I
And one
think
more
the
Only then you will
take-home
be able to see.
message for the beginners and the upcoming surgeons is not to attempt such cases, because all the three speakers were so excellent in their presentations. They should not attempt, in their initial days of practice. Otherwise, they would land up in complications. That I think should be, a very important message, because everything that you all did was
These are all aspiration
great.
cases,
These are
Dr. Isha.
only for, highly experienced surgeons.
No,
This is the
aspirational
disclaimer.
cases.
This is the
You should
disclaimer.
aspire to do that.
This is the disclaimer what you have put now. Perfect.
Can I ask one more basic question? In
Hmm.
these types of eyes, will the IO power of the other eye help in giving us a guidance whether we are little close to a calculation, or does it help? Because in retina we used to do that. We always take the other eye's calculation. So
B scan should you should go by the guidance of B scan to get the AP length, because your corneal parameters are all gone haywire, and you should tell the patient that the post-operative results, refractive surprises will not be a very uncommon thing in such cases.
Taking the other eye's IOL power is a commonly done thing. If you can't get the K reading, what else are you going to do? Yes, B scan axial length is that way a consistent thing. So you can compare both eyes, these things, but if nothing seems to work and there are very haywire readings, then it's better to go by the other eye's readings and put that eye on. Anyway, these are very imperfect surgeries and we don't expect miracles. So what we are aiming basically is ambulatory vision for the patient.
And since all these patients are, I think, elderly patients, I feel that I'm sure they would be having the previous papers of the eye surgeons whom they have seen, isn't it? So all those previous records also should help us for the line of treatment.
okay, ma'am.
Some of these patients don't even remember having any eye surgery done. They would rather remember their haircut but not the eye surgery. So difficult to get any information on that. So we generally, it's an educated guess. We can call it that way.
Shilpa madam, may I ask you one question? What is your view about the combined surgery when it's thick corneal opacity with cataract?
Means
Like
PK.
keratoplasty. Yeah.
Yeah. Yeah, definitely. But again, as I said, if it's keratoplasty involves a lifelong follow-up, taking care of the graft lifelong. So if the patient is not in a position to follow, all this needs tremendous amount of motivation and family support. These factors should also be considered. So, for example, if a patient is bilaterally blind with not in a position to follow, then in spite of having a central corneal opacity, I would not advise keratoplasty if I'm not sure if that patient will follow, because invariably that patient can land up with the most disastrous complication is infection and endophthalmitis if proper care is not taken, and whatever eyesight he has, that also he may lose. So it's better to give ambulatory vision rather than aiming for perfection in such cases. Of course, educated and well motivated people, you can always give them the option of keratoplasty. So it can be PK or even a DALK or DSEC, depending upon which layer of the cornea is involved.
Okay. Thank you.
I would like to just make a couple of points. One is about the iris claw lenses. The thing which I've realized is Dr. Nivian very beautifully demonstrated use of enclaver inserted simultaneously when when you're inserting the lens in the anterior capsule. In the anterior chamber. What I have sort of modified it is I don't take the side ports first. I implant the lens in the anterior chamber, make it horizontal. Then you know where exactly the the claws are of the iris claw lens. So take the side port at that particular point. And when you take the side port, sometimes you may be in the habit of making a slightly longer side ports. Here, you should aim for a slightly shorter side port. So the purpose is that when you're going to insert the enclaver in the anterior chamber, it generally dips the sclera or dips the posterior lip of the incision. So the lesser the length of the side port incision, the better it is to maneuver the enclaver. Second issue is about the Fuchs patients. Even if you do an excellent surgery, either it could be SICS or phaco, but I feel these patients should always be kept under watch because you never know when the corneas are going to decompensate. And oftentimes, especially in any corneal pathology patients, there is always this chance of Descemet's detachment, which is higher than in a normal patient. So I think that also needs to be kept in mind because if you have a Descemet's detachment, it's a very difficult situation to handle. You may have to refer the patient to your cornea colleagues, but sometimes even after the Descemet's attaches, the corneal clarity is compromised and the cornea can decompensate. So just these are a few points which came to mind. Thank you.
Sir, I think you are more than 100% right. So initial 100 cases, we used to do that. It's always good to place the lens in the anterior chamber, make sure you know where you're going to clip and then make the side ports. And the point of what you said, making the side port shorter is excellent because we have had instances where you make it the usual side port and either your instrument goes far as you said, the cornea starts bending. I think very valid points, both of them. It's just that nowadays I do that one-step approach.
Yeah.
That shows your dexterity. So obviously you're a pro.
So I would like to thank everybody for I hand over the webinar to Dr. Anil Shah sir for his thoughts and then vote of thanks, please.
Thank you very much. All the speakers have definitely shown their presentation very nicely, and they have already shown various types of technique which are very useful in complex cases. And the title, which itself suggests is simplifying the complex, they have made all the things very simple. One thing I wanted to add in the Nivians is that they are using Prolin suture for secondary IOL implantation, but I use 50 micron steel suture for secondary implantation because Prolin suture by the time after a few years it goes decay and the lens may subluxate. But if you use steel suture, then the lens remains permanently and the decay doesn't occur. That is one point which I wanted to add. And I am also practicing steel suture in secondary IOL implantation. I am really thankful to all of you for giving this wonderful talk on this series. Thank you very much. Do you have any experience even about steel suture in this?
Yes, sir.
Do you have any experience of steel suture using in secondary implantation?
But after you said, maybe I'll use it and see. Just one small request. It'll be nice if all of you can try the CMT Flex IOL.
CMT Flex is good, no problem.
As an alternative.
I'll hand over to Aarti for.
Yeah, so if in case we don't have any more questions or comments from any of our speakers, discussants, or chairperson, I would like to give vote of thanks.
Go ahead.
So I would like to thank our chairpersons for today, Dr. Prakash Marathe sir, Dr. Anil Shah sir, and Dr. Usha Johri ma'am. our discussant, Dr. Mandar Paranspe sir and Dr. Satanshu Mathur. Special thanks to Anand Bankarkar sir for his expert's comment. I would like to thank all the three speakers, Dr. Nivian, Dr. Shilpa Joshi ma'am, and Dr. Pradeep Mohanta for their excellent presentation. I would like to thank Amay for moderating this session with me. Last but not the least, I would like to thank Team NTOD for all their technical support. I hope I have not forgotten anything.
And all the delegates who have attended, those who have
And
attended.
I would like to thank all the attendees and for attending our sessions and motivating us to continue this series. So soon we'll be announcing our next session. Thank you everyone and good night.
Thank you.
Thank you. Good night.
Bye-bye. Thank
And
you.
we'll be taking another episode on the same topic. And then posterior polar cataract and dislocated lenses, they are remaining. So we will add in the next episode.